So welcome to this first in a series of lectures on evidence-based practice. We'll be using two different textbooks for this series. The first one here we're going to be using is the Scott Raab and Debbie Craig textbook. We'll be going back and forth between the two. As such, when you're using multiple texts as well as different sources, there'll be slight differences in different ways of saying the same thing. We'll investigate all of those. And so it's important as you go through and study in this course that you realize that there isn't a particular right answer for a lot of these different things. It's really just going to be according to what source. We'll see different ways of describing levels of evidence, slightly different definitions, and each one of these are just according to whoever is stating it at that point in time. So it's not right, wrong, they're just different. So keep that in mind, and as we go through and look at the different versions of this, you'll also see that in the course we'll be describing these differences as well. So we'll start first with chapters 1 and 2, again in the Raab and Craig text. Our objectives for today, we're going to try to define evidence-based practice and understand its importance in athletic training, specifically trying to figure out what evidence-based practice is and what it is not. From there, we'll get into the 5 steps that Raab and Craig describing evidence-based practice and making it patient-focused. And then finally, understanding one way of addressing these different levels of evidence. So first, let's look at the definition of evidence-based practice. And when we look at evidence-based practice as a defining term, it's really much more complicated than it sounds. Most of the time when you think of evidence and evidence-based practice, you are thinking about incorporating that best evidence. And that is true. We are going to be looking at research, what's out there in the literature, and trying to figure out ways to incorporate that into what we're doing on a regular basis. However, that is just the beginning of evidence-based practice. What we'll also see is that just because the evidence is one way or the evidence might be lacking doesn't mean that we cannot continue to do evidence-based practice. We also have to start where we always start with treatment or patient care, and that is with the patient. We have to understand what they often refer to as patient values, but really what we're talking about here is understanding both the importance of what the patient wants out of treatment as far as their goals, specifically, whether their goal is to get back to sport participation, whether they're looking about getting back to work, right, or whatever their importance lies. But at that same point, that evidence-based practice has to be patient-focused from the standpoint that we know the evidence might be slightly different, and the treatment approach might be slightly different based on our patient population that we're working with at the time. So evidence-based practice is first and foremost patient-focused. Secondly, now, once you combine the evidence, you also have to take into account the art of athletic training, or specifically you as the clinician's experience, training, and understanding. As we combine those two different areas of knowledge, both what we already know, what we are able to do, as well as what the literature says, we can combine that with the outcomes that are important to the patient, and that now becomes our evidence-based practice. So as far as what we mean by evidence, that's what we'll spend most of this course focusing on, is the evidence portion of that. We talk about patient values and outcomes as the primer for everything that we do, and then basically the rest of your education in healthcare is making your own clinical expertise. And so we need to separate out specific time to look at the literature and the research, and so that's what we'll do. So when we talk about clinical evidence, this legitimately is all available evidence or literature or sources that you can come up with. Really anything that will help drive your decision making beyond your current level of knowledge. And so most of the time what we're doing is we're looking to the research in the fields of athletic training and sports medicine and trying to incorporate what has been studied out there and how that might apply to our specific situation that we're going through. And so it's important to understand that although we'll spend a lot of time talking about research studies because that is the most complex form of clinical evidence, there is lots of different levels of evidence. And the reason we specifically look at the literature is because each of these studies is designed to answer a specific question. And in answering the research question, we can help then understand and design our study. And we'll see it, or our patient care. And we'll see as we go through this idea of randomization and how that can become important when we look at the different levels of evidence. Clinical expertise, I mentioned this briefly before, but this is everything else beyond the current literature, what you already know. And it's also important to understand this can be a real sense of pride for you, understanding your current level and what you're good at. And in fact, it may be possible that you doing something that you're good at and you're very comfortable is better than something that might be similarly effective, but you're not as comfortable with. Patient values, not much more to add to this. You can see some of the things described by the authors of your course text here. But really, when we understand and we go through and enter into treatment or decision making, it's always important to understand the role of the patient. And the patient is going to bring with them their own sets of ideas and their own knowledge. That knowledge may or may not be completely reliable, but it's important to keep that in mind. We talk about things like placebo effects, and we talk about that as an effect that cannot be attributed to the actual treatment itself, but into the belief of the treatment. And so when we get into these different areas in making treatment decisions, a treatment that the patient believes in is always going to be more effective than a treatment that they don't. So oftentimes it may be possible that the best course of treatment would be to perform a skill or an intervention that is actually solicited by the patient just for that belief factor. So Rob and Craig describe a 5-step evidence-based practice model. There are different models that we'll see with this. This 5 steps is pretty common as far as a basic model to go through. And we'll see some of the differences when we get into other sources. But these 5 steps serve as a good framework to at least begin with. And we have to start somewhere, so we'll begin with this 5-step evidence-based practice guideline. So the first step in this is creating a searchable question. The idea here is that in order to use the best available evidence, we first have to describe what we're looking for in a way that will allow us to reach that best evidence available, understanding that there is so much research out there in this informational age that could or could not be relevant to our specific case. We got to find a way to create both a focused and searchable question. And so one of the formats that has been used commonly, and we'll see it described a variety of different ways, but this idea of a PICO question. And the PICO question simply gets into a format that will allow us then to have a focused and searchable question. So PICO is just an acronym for patient and problem. Either the patient population or the specific issue that we're going through, the intervention or our treatment, the comparison, and then the outcome that we're looking at. Step 2 is going to be now searching and finding the literature. This is a both complicated and relatively simple at the same time approach. The idea legitimately is that depending on the amount of literature and the amount of information available will depend on how good we need to be at searching. You can literally just Google anything and get hundreds of thousands of hits, and the information that you want is probably in there somewhere, but going through all of that information would not be a good use of your time. Even Google Scholar, different things like that, make it more difficult. So you can use more specific databases that are associated then with the care or with the condition or patient population that you're most looking at. And each different database has different journals associated with that database. And so that narrows it down somewhat. There's also different search engines that can be used as far as searching the internet, or different services that can come into play as far as different usually paid for services where they do some of the research for you to begin with. Step 3 then is to critically appraise the value of that evidence. And the basic idea with this is we need to understand that not all evidence, not all sources are going to be created equal. The same way we might get advice from a bunch of different people, what we end up doing with that advice simply isn't an adding or subtracting formula. Some advice is worth more than others. And so the same thing occurs when we're looking at our evidence for evidence-based practice and our clinical decision making. We have to understand the quality and applicability. And sometimes this is referred to then as both the internal and external validity of the information. And we'll get into this critically appraising the literature more in the future as far as how to do this, as well as the categories. Step 4 then is we actually have to make a decision. And so step 4 can simply be phrased as making your decision. You have to go through the different information that you have gained, both from what you already have as well as what the literature says. Put that into the context of both your own experience, your comfort level, as well as what the patient is looking for and the patient-specific components associated with that. And then you're going to end up taking and applying that to applying your decision and actually going through and implementing your treatment. The 5th step wouldn't think to be part of the normal system, but it's always important that we spend time reflecting and assessing our outcomes. One of the best ways to guard against potential errors in treatment is to constantly be assessing your outcome. First and foremost, was the treatment effective? Did we receive the result that we hoped for? And this can be in a variety of different ways. First, is the patient getting better? Now, if the patient's not getting better, that can be a result of multiple things associated with it. But the most important component is that means that something needs to change, whether it's our diagnosis or it's our treatment plan. But to continue down the same road with ineffective treatments is the #1 way to get yourself in trouble and not provide good care. So those are the 5 steps that are often described. The next component in this introductory lesson from Rob and Craig is to understand this idea of the clinical evidence pyramid. And this really goes back to step 3 as far as critically appraising the literature. And so although we will get into much more depth in how you do this, it's important to first understand that there are going to be different levels, and each of those different levels are going to describe the methodology for their research slightly differently. And so there's a reason for each one of these. As we get into higher levels of evidence, we're going to have fewer studies but higher quality. And that has to do with the specificity of the research itself and the amount of possible variables that go through. So we want in research to have single variable questions where basically we can attribute all of the difference between the groups to the effect of the intervention that we're testing. Obviously, as you eliminate variables, you get more and more specific, which means you can be testing less and less. And so with that, it inherently means that there will be fewer of those studies. While at the same time, we also need to understand that each level is going to have its overall strengths and weaknesses and have a specific purpose associated with that. And we'll see that it's not always possible to have the highest level of evidence in every situation. And so we need to be somewhat understanding of that. And we're going to be using the highest amount of evidence that we can as far as different levels, but we need to consider all evidence within our treatment approach. So when we get into this, we'll see here shortly one of these descriptions, and there are multiple different descriptions that label the category slightly different. Now, as we go through and look at these, the important thing to note is that the types of research does not change as far as some being of higher quality than others. It's just simply how we're going to categorize these and label these. It really is a continuum of methodological quality throughout the entire amount of literature associated with whatever we are searching for. And so keep in mind that when we think and we talk about level 1 versus level 5 and level 1A or B or all those different things, that these are simply categories that we have artificially applied to these different research levels. And so it's not as important that we specifically know each category, even though we will need to learn the different categories that have been described by different groups. But it's more so important that we understand this different idea of a hierarchy. And so when we get into this highest levels of research, this is legitimately what you think of as your normal amounts of research and literature. When we talk about peer-reviewed sort of things, we're usually talking about our RCTs, or randomized controlled trials. And the randomized controlled trial focuses on this randomization, hence the name, critically appraised topics, systematic reviews, and meta-analysis. And so this is the first chart that we will look at associated with different levels. And so when you look here and you begin at the bottom, you can see that background information, expert opinion forms the foundation of this pyramid. And so this is simply going to be somebody that has studied this, but it is just as it says, their opinion. Case-controlled studies, case series, and case reports are going to be simply describing very small, in the case of a case report, one patient and how that responded to that. Cohort studies are going to be studies associated with predefined groups. So it's sometimes cohort studies are referred to as quasi-experimental, meaning that the experimental design is there, but without randomization, we're adding additional variables that might become problematic. Those randomized control trials are next, critically appraised topics, and then the systematic reviews. So what does each of these mean that we're talking about? Well, what randomization means is that each participant has an equal chance of being in the treatment or the control group. And what this does is, by having a true randomization, we'll have regression towards the mean of all other variables except for the intervention. And so the idea is that if I randomly assign people, I will end up with similar numbers of men versus women in each group, smart or not as intelligent, tall and short. All these different things that might affect the outcome are going to be randomized, and that's the best we can do for controlling that. Critically appraised topics then. Now, what a critically appraised topic is we're now going beyond a single research study. So the randomized control trial is considered the gold standard for a single study. But once we go beyond that, we need to know what all of the literature says, not what a single study goes through. So critically appraised topic is basically somebody having already gone through the evidence-based practice 5 steps and telling you what they have found. So it's going to be a published article basically describing their findings. A systematic review now is all-inclusive, and what that legitimately means is the systematic review differs from the critically appraised topic from the standpoint that in a systematic review there is a published methodology that the researchers have followed, and all research that falls within that methodology, meaning their search parameters, all research has to be included. So the difference between a systematic review and critically appraised topic is, in a systematic review, the author has no ability to decide which articles are included and which articles are not. They are decided ahead of time in the methodology, and if a article reaches the methodology requirements, then it's included regardless of outcomes. The meta-analysis then goes one step farther to take the systematic review process and then recompile all of that data that's associated with all those different studies and reanalyze them using new statistics. And so it's like basically rerunning the study as if each participant in all of these different studies were then tested again. And so the idea with a meta-analysis is not only have we included every study that is relevant, regardless of potential author bias, we are then also compiling all of that data to create a patient population or intervention group that is much, much larger. Most systematic reviews might have, in the dozens of participants, whereas a meta-analysis then might have hundreds. And as we increase the number of individuals, randomization becomes more and more effective. So, like, if you think of flipping a coin, right? It's possible that if you flipped a coin 4 times, you might get heads 3 times and tails once. And from that, you would assume that the chance of getting heads is about 75%, which obviously we know is a statistical anomaly. The chance is 50%. As I go up and continue to flip the coin, I will get closer and closer and closer to the 50% mark. And the reason for that is because that law of average and regression towards the means is going to occur. And so as we increase the number of participants that we are evaluating for each individual intervention, the more we will get the regression towards the mean, the filtering out of all other variables that are not associated then with the intervention, thereby making it easier to determine that the actual difference that we see between the groups is a result of the intervention and not some sort of confounding variable. As far as filtered, unfiltered in the TRIP database, basically this is an example, and just one example, of those possible pay databases associated with evidence-based practice. There are multiple of these that are there, and basically what the filtered versus unfiltered does is each article that is published in the vast majority of journals, right, are peer-reviewed, meaning that before they are published, they are reviewed by another set of researchers. What this database does is it then goes one step farther and it reviews all of the published articles and giving it a second peer review process, thereby increasing the level of understanding of the methodological quality associated with that article. And so the idea is these filtered articles are giving you a better idea of what is occurring with less work. So when we talk about how to critically appraise each individual article later, one way to avoid doing this is to use a paid database like the TRIP database, and thereby allow you to understand and have some of that critical appraisal done for you already. So when we get into the purpose of evidence-based practice, and this is just wrapping up from the idea of why does any of this matter? And the first and foremost reason is because it leads to better patient care. We need to, as a profession, continue to move towards providing the highest level of care possible. And in order to do that, we need to have proof that what we are doing is effective for our patients. And so we need evidence to justify that. And so what this evidence does is it leads to elimination of poor performing interventions and replacement with higher performing interventions. And you see this throughout the history of athletic training education as different interventions and different treatments are taught and how they are taught specifically. So the idea that some things that were taught 10, 20, 30 years ago are no longer taught because we've seen them to be ineffective. An example of that is the de-emphasis of something like contrast therapy, alternating from hot to cold, to reduce lymphedema. There might be all sorts of different reasons for that, but the ability of that to enhance the reduction of lymphedema through a vasoconstriction and vasodilation kind of pumping mechanism has not been shown in the research. So evidence-based practice is a way of eliminating those low-performing outcomes. At the second component there is finances, and these financial constraints can go both ways. First and foremost, you need to understand the value of what you are doing for the possibility of reimbursement. If you expect somebody to pay for what you are doing, it makes reasonable sense that they would require some sort of proof that what you're doing is going to help them with what they want. And insurance companies have been requiring research for interventions that they pay for a variety of different health professions for a long time. And athletic training will need to continue to move down that road if we ever would like reimbursement for services. And so when you hear about like experimental treatments, different things like that, not being covered by insurance, that's basically what they're talking about, that there is not sufficient evidence or proof that the modality or intervention is effective, and so therefore the insurance company is not going to pay for it. Also in the financial constraint component of evidence-based practice and its importance is most of the time you have limited amount of resources. And so you need to be able to spend your resources on what's going to be most effective for your patient population. And that leads into this idea of effective time management. The interesting thing about evidence-based practice in all of healthcare, but specifically in athletic training, is research has shown the #1 reason for not performing what is considered evidence-based practice is a lack of time. And the idea with this is it takes a significant amount of time to do the research that you need to gain the evidence. So those steps 2 and 3 that we were talking about. However, it can also be argued that evidence-based practice actually leads to a net increase in the amount of time because it decreases the amount of interventions that are done overall because you stop doing ineffective interventions. Oftentimes in athletic training, in an effort to show that we're doing something, you often end up just throwing more and more and more interventions at the patient. The idea that, we're not really sure if it works, but it's here, so we're going to do it anyway. And so if you practice using evidence, you can eliminate some of those treatment that are not needed and they're not doing anything anyway, thereby increasing the amount of time. So you can use patient education through the evidence-based practice in that step 5, analyzation and reflection, to explain that possibly a intervention is no longer needed or is not needed at all. I use the example of preventative ankle taping, right? You can spend a lot of time taping ankles and a lot of money on that. And ankle taping has been shown to be relatively effective in decreasing overall ankle motion, especially in the early phases right after taping. However, the evidence is much more mixed when it comes to actually preventing ankle sprains. And really, our goal is not to prevent ankle motion, but to prevent ankle sprains. And the mixture of the research can be divided out into basically, do they have a history of ankle sprains or not? If they've never sprained their ankle before, research tells us that you would have to tape their ankle, thousands of times in order to prevent an ankle sprain. So you might have to tape them their entire collegiate athletic career every day in order to prevent a single ankle sprain. Well, if you think of that from both cost of the amount of tape, but also from a time standpoint, it would be a lot easier to treat the one ankle sprain that may occur as a result of not taping, opposed to taping that athlete for their entire collegiate career. And so we can actually use evidence-based practice and the patient education associated with evidence-based practice to eliminate some of the treatments that we do, opposed to just always adding more and more. So to wrap up this lesson, we'll go back to our objectives. First, we defined evidence-based practice and its understanding. Really, the idea there as the evidence-based practice is the use of best evidence with clinician expertise, all within the framework of the patient value to deliver the best overall care. We talked about the 5 steps of evidence-based practice, the forming a question, finding research, evaluating that research, making a decision, and then reflecting, and then the idea of the different levels of evidence. And we will spend a lot of time talking about levels of evidence. So if you're still struggling with what that is or defining that, that is okay. We will have specific lessons just on the levels of evidence.